Hello and welcome to the channel. This is Dr. Prashant Shukla, and today I have come up with a routine phacoemulsification of a patient who is having very dense cortical cataract with these very fine and dense cortical opacities, and the case has already been started. By this time the entry capsule has been stained with trypan blue and entry chamber is now being filled up using 2% HPMC. Some HPMC is sprayed over the corneal surface. In these kind of cases where we have very dense cortical opacities, getting the rhexis right is a challenge, and many a times we tend to lose the rhexis because of these dense opacities, as we don't have a very good fundal glow, red glow. So it is a good idea to always stain the capsule and go slow and always do the rhexis under direct visualization. So now I am taking a micro rhexis forceps and slowly under direct visualization my microscope is giving a very good red glow even in such dense opacities. And now I am towards the end of the rhexis completion, and I've got a decent size rhexis, about 5 to 5.5 millimeters, well centered. Seal keratome is being taken now, and a main phaco entry wound is being made. One more side port is being made for introduction of the chopper. Hydrodissection is a very important step in these kind of cases because we tend to have very strong adhesions between the cortex and the capsule, and we have to do a very thorough hydrodissection, cortical cleaving hydrodissection at multiple places so that we have a very free nucleus inside the capsular bag, and one has to be very sure that the nucleus is freely mobile. I am doing multiple small waves of fluid, and now I am going to take a Sinski and just check the rotation of the nucleus and be sure that all the corticocapsular adhesions have been removed. The nucleus is spinning very nicely. Now is the time to introduce the phaco handpiece. Here I am using a 2.2 tip, and the vacuum in sculpt mode is about 75, bottle height is about 90, and power is about 45. The superficial cortical and lens matter is now being removed, and now is the time to do some sculpting. Thin long trench is being made up to at least 80% of the depth of the nucleus. The phaco part in this case is almost unedited. After reaching sufficient depth, now I am using a long Sinski to just separate the two heminuclei using phaco needle and a long Sinski. Now I have got two heminuclei. Settings have been changed now. The vacuum is around 250, power is 50, bottle height 110. And one heminuclei is being chopped into multiple small pieces. The grade of the nucleus is not very hard, so sometimes it's difficult to get a firm hold on the nuclear fragments. I am constantly moving the microscope head with XY just to keep things in center, because many a times when we do surgery and surgeon has got a peripheral view also. So I would be seeing through the microscope, but it's not very evident on the screen. So I always ask my assistants to just always check the screen in the operation theatre whether the eye is centered or not. So now I'm going to emulsify the second part of the heminucleus. Time to replenish the OVD just to protect the corneal endothelium. I always prefer to put some viscoelastic at least twice during the surgery so that we have a very clear cornea the next day. Although the nuclear grade is not very hard, so there is not much of a difficulty in emulsifying these small fragments. And the last piece is now engaged in the phaco handpiece, and with moderate vacuum and power settings. I am not using very high power because I am purposely avoiding any chattering. I always want the pieces to be near the phaco handpiece, phaco tip, and do not hit the corneal endothelium. Now is the time to remove the remaining cortical matter, whatever is left, into the capsular bag. I am starting subincisionally because I feel that is the most difficult part to remove. So I prefer removing the difficult part, subincisional part first, and then I move to other areas. Many a times I have seen, in spite of having a very good hydrodissection, the cortex is quite adherent to the capsular bag. So I am gently stripping the cortex using a vacuum of about 350, and gradually some part of the epinucleus is also there. It has now been flipped, and there is some part of cortical cataract also, which is at the equator. Now gradually it's being removed, gentle stripping. I am taking cautious care that while I am aspirating, the aspirating port of the coaxial IA is facing towards the cornea and not towards the posterior capsule. I am constantly moving the probe. While engaging, I am facing the port towards the cortex, and while aspirating at higher vacuum, I am just rotating and facing the port towards the cornea. So by doing this, we can just avoid any inadvertent catching of the posterior capsule and any further complications. So now the cortex and the epinucleus has been removed, and we have a very clear capsular bag. A single piece monofocal hydrophobic spheric lens is being implanted. One haptic goes into the capsular bag, then using the same Sinski, the other haptic is also guided into the capsular bag. Now I am removing whatever viscoelastic is there in the eye, first from behind the lens and then from in front of the intraocular lens and the anterior chamber. We should try and remove as much as viscoelastic from the eye to avoid any post-operative IOP spikes. And here I am towards the end of the surgery. Viscoelastic is being removed. Case is done, and hope you like the video. Do like, share and subscribe my channel, and keep following for new updated videos. Thank you so much. Always check the integrity of the wound and the proper closure before removing the speculum. That's it. Thank you so much. Have a nice day.